Welcome everyone to another week with live with Dr. McDougall. We are, as usual, very excited and thankful for Dr. McDougall to give us this hour every Thursday. And we're continuing with this great, this marvelous book that he wrote several years ago, Digestive Tune-Up, but it's it's up to date because everything that Dr. McDougall writes is correct and it's the truth from the beginning, so he doesn't need to do another edition and make corrections. Dr. McDougall is an internist and doctor that takes patients like any other doctor. He is not an alternative medicine doctor. And today he's going to talk to us about chapters 5 and 6 from this book. I hope you all had the chance to read it, to read those two chapters. And the two chapters talk about ulcers and gallbladder. Very interesting topics. And Dr. McDougall, welcome today, and thank you for being here once more. How are you doing today?
Oh, good. Oh, good. I'm doing. Yeah, good. Let's see. There was a big study that came out from Australia. I believe it's called the Broad Study, and it was a study of, it was a randomized controlled trial of our diet, giving John McDougall credit. And that came out this week, and that was kind of cool. And I meant to have a copy of it here for you, but I just didn't get it done. And then, I don't know whether you can do this or not at this late stage, because I didn't tell you, Gustavo. But under our Star McDougallers, there's a lady by the name of Paula. And what she says is that she changed to basically our diet. And she was skeptical. She gave up all the junk foods. And she said, after weeks, my symptoms and pain started to fade. After a couple of months, I felt better than I ever had. I never got surgery. 6 years later, I can't imagine eating any other way. Good food changed my life. And this is on, I just printed it out. I don't have the actual article, but Mary looked it up and said it is online under this section in People's Magazine called Lenny Letter, Lenny Letter. So that was in Tuesday's People Magazine. That would be Tuesday. This is March 2017. So that would be on the 21st of March would be Tuesday. So anyway, there's a case of endometriosis. I don't know whether are you able to find Paula with endometriosis? Yeah, there it is. Okay. Yeah, great. That's fine. You'll find any of you who are looking for this. I wrote this maybe 10, 15 years ago. This is Paula, and she had terrible endometriosis, could not get pregnant, and changed her diet, and her endometriosis went away, and she had this baby that you see in the picture. There's some other pictures. Oh, there's a big boy now. I met Nicholas when he was 9. They went to a McDougall adventure in Costa Rica. So I met him at 9, and I actually had a chance to meet his dad 2 weeks ago. And his dad said, he said something about his wife having endometriosis. I said, I know this lady that I took care of like 10, 15 years ago, had endometriosis, got pregnant, and her name was Paula. He says, that was my wife. Excuse me. So anyway, everybody, nobody connects endometriosis with diet. But I do, and understand why, because what you eat dramatically changes your sex hormones. And this is a disease of proliferation of the endometrium, the inside lining of the uterus, where it starts growing outside of the uterus and gets all over the fallopian tubes, and you have terrible pain from the growths, these endometrial growths all over the inside of the abdomen. You become infertile in most cases. And I've had several women in my career change their diet, and Paula's the only one that wrote the story. So if you want to read about Paula's story, just go to the Star McDougall section, look under written stories, and it's under it's under her name, Paula, and endometriosis. You won't have any trouble finding it. And you'll see, and I can't tell you when I wrote it, but it was probably 15 years ago. So here we have in this week's People magazine, I guess it's an online section. I don't know, folks, you're going to have to find it yourself. And she was in terrible pain and depression. And then she says, I changed my diet, to the diet that we recommend. I have no doubt it is, otherwise it wouldn't work. And the quote is, to my surprise, I'm still surprised. It actually worked, she writes. After weeks, my symptoms and pain started to fade. And after a couple of months, I felt better than I ever had. I never got the surgery. 6 years later, I can't imagine eating any other way. Good food changed my life. So that's what, somehow associated with People magazine this week. You look it up. That's the best I could get. I just got this note about 5 minutes ago. One of the reasons that I'm looking a little bit a little bit rushed, a little harried, rushed. So anyway, that was kind of cool. I told you, and I'll show you the article next week or next time I get on, the article from Australia that studied the randomized control trial of our diet, my name in it. Randomized control trial, and it showed tremendous benefits, the greatest weight loss of any program that's ever shown. Published in a serious medical nutrition magazine. We're talking about something with great reputation. A great publication will make a big difference. I just didn't have time to get it together, but I barely did have time to get something else together for you. I tell you,
what is that?
Things are just seem to be going so fast. I almost feel like we're going to take over the world. This is the magazine that came out this week. Do you recognize this magazine? Do you recognize that magazine? Martha Stewart's magazine, Living? All right, now here's what the problem is. Mary marked the page where the article about me is in there. Oh, here it is. Okay, here. I'll try and show it to you the best I can. You see this page? That's a potato. Now, I know it's fish on the other side, but somebody got a little screwy.
Yes.
But see the page right there? That's a potato. Yeah, and I'll see if I can read some of it to you. It says, be smart about starch. Be smart about starch. Here's a reason to rejoice. It turns out that eliminating carbs from your diet is actually a crime against nature. Last year, researchers from the University of Oregon found a seventh taste bud on the tip of the tongue that's a receptor for starch, says Dr. John McDougall. Right there, my name. Martha Stewart.
Oh, wow.
Pretty soon she's going to be tuning into the webinar and calling me up and asking me asking Mary to do cooking demos for her. Martha Stewart. Anyway, your body, John McDougall, an internist and author of The Healthiest Diet on the Planet, Harper 1. Your body craves it for reasons. Carbs are full of fiber and satisfying. Historically, it was the primary source of food for all large, successful populations. They ate rice, potatoes, wheat, among others, McDougall says. So incorporate good old-fashioned rice, bonus points for brown kind, which has a lower glycemic index, or potatoes, but hold the fries into meals, along with more exotic varieties such as black rice and amaranth and so on. I mean, can you right here?
That is awesome.
What is it, Martha Stewart magazine?
Awesome.
It's the April issue, by the way. It just came out.
Yeah.
April issue, so it'll be on the newsstands for the next month. Oh man, I can hardly keep up with this, The other thing I probably shouldn't mention too much, but I will be talking about it as time goes on. My connections with Kevin Hall from the NIH, and I've talked to him a lot about him. He was at our last advanced study weekend. You met him, Gustavo. They're warming greater than I ever expected. So I hope that maybe within the next 3 months, 6 months, year, 3 weeks, I don't know, that I can tell you that the NIH has serious interest in the McDougall diet. And then maybe we can prove to some skeptics that, there are people out there that that believe anything. If I appeared in Time magazine, already in People and Martha Stewart's Living, I don't know if it would even change any minds, Gustavo. I just don't know whether minds are changeable.
They're changing. I think minds changing. I mean, not like you said, not everyone, but there is a change.
The question is fast enough. Ladies and gentlemen out there, I'm talking to you. Don't walk, run. Run to your neighbors, run to your friends, run to your relatives, get in their face, put on your prettiest dress or handsomest suit and say, look at me, this diet of sweet potatoes and potatoes has made me gorgeous. I can now run a half a marathon in half the time, or whatever you have to say. Make this half of the words that come out of your mouth all day long, that we have to do this change. It's really frightening for me, but I do think I talk to Mary a lot, as you well know, as my best and probably only friend. I got a lot of friends.
No, that's really not.
Well, my most serious friend. When I talk to her, I say, we're going to save this world for our children and grandchildren. But if we all got together, we worked really, really hard, and there was a 1 in 1,000 chance we could save the world, we should try and do it. And I will, and I won't stop. And that's what I had to say. Anyway, so here we are. I talked about the Digestive Tune-Up book.
Yes, there it is. Okay.
Yeah, and I do again want to give credit where credit is due to my my friend Howard Bartner. This picture is in the book, but we showed a nicer picture last time of Howard. And last time we talked about the teeth and gums. And
let me know when you want me to start the PowerPoint.
I will, thank you. And we just kind of review. We talked about how your body stinks because of the food that you eat. And I got an email afterwards from a person who listened to the webinar, and she said, and I'm probably going to get all the facts mixed up, and please excuse me because I read it about 6 days ago. But she told me her dad, who was in World War II, that the Asian prisoners of war that were intermixed with the American soldiers, they wouldn't sit with the American soldiers because they stank so bad. They smelled so horrible. And I've heard these stories too. I'm of the Vietnamese war era. I was peripherally, thank God, involved in the Vietnam War. And my friends would come back and they would tell stories about how the Vietnamese, when they were downwind from the Americans, they could smell them. And that's one way a lot of Americans got killed, was that they smelled so bad from the meat and the dairy that they were fed by the U.S. Armed Forces, that the Vietnamese soldiers who lived on rice and almost no meat and no dairy would be downwind from them, could smell them and just sit and wait for them and kill them. So, and I hear stories. Other stories I hear about is about how, I've read several books about Inuits, Eskimos, which I know Inuit is probably the most proper name, but about Eskimos and how visitors to that part of the world, one of the things they noted was how they smelled like fish. And ladies and gentlemen, just to review last week's webinar, if you eat sweet potatoes and corn and rice, that's what you're going to smell like. Eat dead pigs, dead cows, mammalian secretions, coagulated or not coagulated, fermented or not fermented. You eat fish, goats, lambs, cheese. What do you think you're going to smell like? All right, let's get out of this stuff.
That's exactly right. Like that.
Because I had a lot of fun delivering that lecture last time. Well, let's see what we got in these chapters. I think we're going to talk a little bit about, and I'm going to have to refer to this. Let's put up the first picture of the stomach. There would be Larry standing there with two stomachs next to him. Let's go to, well, it's a good one. I don't think that's the exact one, but let's go with that one. No, go back to that one. What we're going to be talking about, last time we talked about from the teeth, you see that. You go back into the pharynx, the back of your throat, and the vocal cords are right there in the back of your throat. And then the long tube is the esophagus. It's that long tube that goes through the chest and then goes into the stomach. You see the stomach there. And then I want you to look at the end of the stomach. There's another smaller tube. That's the beginning of the long intestines, small intestines, small intestines. And it's called the duodenum or the duodenum. And we're going to be talking a little bit about the duodenum. And what I want you to know is off that duodenum, that's the last part of the stomach where the small intestines start. At that last part of the duodenum, some ducts come off. Those are ducts that go to the liver and the pancreas. And so I just want to get you oriented to today's discussion about the stomach and about the liver, which is, the white area just behind the stomach, and the duodenum, where the ducts from the pancreas and the liver go into. So you get, because it gets a little confusing if you're not familiar with anatomy about what we're talking about. All right, so let's see what we got for the next slide. That's the one I was thinking about. See, this is the end of the esophagus going into the stomach. And what you see in the first stomach is you see that the end of the duodenum is closed. That closure is called the lower esophageal sphincter. And that is supposed to be closed between meals. And when you swallow, the food goes down the esophagus, and that muscular constriction, that sphincter, relaxes and allows the food to pass into the stomach where it begins its digestion. Or it doesn't begin it, it begins in the mouth, but where a lot of digestion goes on with hydrochloric acid and so on. So that's supposed to be closed. But what happens in a lot of people is that sphincter becomes incompetent. The lower esophageal sphincter becomes incompetent, and it remains open between meals. And then you get a condition called purple pill deficiency. That's a joke. That's a joke. You get a condition you learned about because of the purple pill,
right?
Because of Prilosec and Nexium. When a drug company devises a product, invents a medication that has physiologic effects, they have to teach the customer about their need for their medication. And so when these pills came out, people learned about GERD, gastroesophageal reflux disease. Before that, they just called it a stomach ache or indigestion. But the drug companies made the customers so that everybody in the world knows about GERD. They know the term GERD. They know gastroesophageal reflux disease, thanks to the drug companies. And yes, a lot of people have this. So many people have it that you can walk in the United States in any drugstore, in any supermarket, you can see Prilosec or other of these kinds of drugs, which are called proton pump inhibitors. You can see them for sale over the counter. You don't need a prescription. And people are buying them by the hundreds of millions because they're sick with stomach trouble. And somebody who has a incompetent lower esophageal sphincter, what happens is the stomach acids and other contents, they reflux up into the esophagus, and you see how the esophagus is red. Okay, that esophagus is being burnt. It has esophagitis. It is irritated. It is painful. It is maybe referred to as indigestion. It hurts because you have that constant bathing of the lower esophageal tissues with stomach acid that's not supposed to be there. The sphincter is supposed to be competent and keep the acid in the stomach between meals. Well, this burning gets really bad sometimes, and they call it a condition called Barrett's esophagitis. And Barrett's esophagitis was probably named after a guy named Barrett. but that's just really severe burning. And then the burning gets so bad, so long, over a period of time, that it turns into adenocarcinoma of the esophagus, which is basically a fatal disease. They are not going to fix you. I mean, they may fix you in the sense of taking it out so you can swallow, or doing some rerouting of your intestines so that you can get food down. But that's a deadly, deadly, deadly cancer, adenocarcinoma of the esophagus is. Now, your question right now is, how does that lower esophageal sphincter become incompetent? I'm not going to tell you. I'm not going to tell you till we finish this book. And at the end of the book, I'll tell you how it becomes incompetent. But it's due to the American diet. And once it becomes incompetent, it can't be fixed. I mean, well, it can. I mean, surgeons go in and they do hiatal hernia surgeries and kind of tighten that area up and try and give it support. But it really can't be fixed. But if you eat good food, then you dramatically decrease the amount of acid in your stomach, because acid is there to digest animal proteins. So you get almost everybody who has GERD, almost every patient who I have on proton pump inhibitors, like Prilosec, Nexium, Prevacid, et cetera, almost everybody that I take care of at the clinic. There are exceptions, but there may be 1 or 2 a year. And I would say 20% of people come in on those medications, 10%, let's just say 10. Maybe 1 or 2, I have to leave them on those proton pump inhibitors, but others just changing their diet, all their symptoms go away and they don't have any problems. Now, so that's one thing I do. The other thing I do is I have them raise the head of their bed, because that way gravity at night, gravity, that's, you know, the head of the bed is up, and like about 4 inches on a 4-inch block, 4x4 or a brick. That way the gravity pulls the acid out of the esophagus back into the stomach. So I do that to help them also. And then I will give them, if I have to give them medicine, I'll give them wafer antacids like Tums. You know, there's nothing special about Tums. There are all kinds of wafer antacids. It comes in wafers and liquid forms. That will give temporary relief. And sometimes they can use those on occasion when things aren't going well. And then next, I'll use H2 blockers. They're called H2 blockers, like Zantac. They're sold over the counter too. They have significant adverse effects too, but not like proton pump inhibitors. Proton pump inhibitors are very dangerous. I had an article I showed you. Oh, I showed you about them in kidney disease a couple of weeks ago. And they also cause osteoporosis in a manner that we're going to talk about. Maybe today we'll get to it. And increase in pneumonia, infections of the lung, fatal infections of the lung. These proton pump inhibitors, if you can get off of them, ladies and gentlemen, get off of them. And talk to your doctor if you think you need medical advice to stop them, but you probably started them on your own anyways. Anyway, so let's go on to the next slide. So when that stomach contents of acid and partially digested food, when it refluxes, you see the reddish area right above the stomach. That's the esophagitis, and the Barrett's esophagitis, and eventually the adenocarcinoma of the esophagus. But that acid keeps going up the esophagus, and goes up to the vocal cords and causes chronic cough by irritating the vocal cords. And it also causes hoarseness. And then the acid keeps flowing up, and it gets on the teeth, and it takes the enamel off the teeth. And dentists run into this daily. People with enamel that is eroded off their teeth. It's from the stomach acid that gets on your teeth from having an incompetent lower esophageal sphincter. And then that acid keeps moving up, and it gets into your sinuses, and it gives you sinusitis. And then that acid that's in the back of your throat, you inhale it into your airways, into your lungs, into your bronchi, and you get bronchitis, asthma, and even emphysema from chronic irritation. And this is standard medicine. Now, you go to almost any doctor, certainly any well-informed doctor, and they'll tell you if you have asthma, it can be and probably is due in part to gastroesophageal reflux disease. And what they'll do is put you on proton pump inhibitors, which I'm telling you not to do. What you should do is you should raise the head of your bed. You should start eating food that does not have animal protein in it. And, take an occasional wafer antacid, or at worst, take some Zantac, these H2 blockers. And that's the way that I would handle it for you. If you have asthma or bronchitis or any other suggestion that this is due to gastroesophageal reflux disease. I hope that was all clear to you. Gastroesophageal reflux disease refluxes acid up your esophagus, onto your vocal cords, onto your teeth, into your sinuses, and is inhaled into your lungs and gives you just a whole bunch of trouble. So it'd be better not to get the incompetence of the lower esophageal sphincter. It would be better, but you're not going to learn how that happens till the last lecture from this GI book, how this occurs and how you'll want to prevent it if you can. So let's now take a look at the stomach. And you see the stomach goes into the duodenum. Okay, here's a bigger picture of the stomach. And Larry and Louise are kind of showing you something there called an ulcer. Ulcers used to be, well, they're still common. But when I was a beginning student, we used to think ulcers were due to being neurotic, to being due to anxious. And we felt that these emotional disturbances produced more acid in your stomach, and as a result caused ulcers. And so what we used to do back then is there's a nerve that comes from the brain to the stomach. It's called the vagal nerve. I mean, I did this every day. I put myself through medical school as a surgical nurse. I worked in an operating room 8 to 16 hours a day doing, assisting in surgery. So I do one of these operations a day on a patient, I as an assistant, a surgical nurse. And they would go in there, I believe we went through the chest wall, and they'd find this nerve and they'd cut it, believing that it was influences from the brain, this anxiety, this emotional disturbance that was causing more acid via the vagal nerve. So we go and cut that nerve, which was absolutely, this is archaic medicine now. Nobody ever does this. This is just because we know that's not what causes ulcers. And then the other thing we do is we go and we cut out part of a person's stomach so that they made less acid. That's another way we would cure ulcer disease. Barbaric, unbelievable. But, I'm of an age where we used to do that. I did it every day as a surgical nurse. I was in an operation on this. What was discovered, and I'm not going to give you the date because I don't remember it, but you can look it up. It was maybe 30 years ago, maybe 20. The two investigators that discovered it actually got the Nobel Prize. They discovered that ulcers were due to a bacteria, H. pylori, Helicobacteria pylori, H. pylori, we call it. And H. pylori resides in the stomach of about 40% of people in developed countries like Australia, New Zealand, the United States, European countries, and so on. About 40% of people harbor this bacteria. But in underdeveloped parts of the world where they don't get ulcers, 100% of people are infected. All right. So first of all, this tells me that it's not just the bacteria that are the culprits. You also have to have a diet that makes these otherwise benign bacteria, normal, maybe even healthful residents, turn into nasty little buggers that make holes in your stomachs. And I believe that's the food. You put in meat, red meat, poultry, fish, cheese, milk. Milk is a horrible thing. You put those things in the stomach, and then those bacteria turn pathologic. and you give you ulcers. Well, what the great treatment came out of this discovery of H. pylori bacteria is doctors developed a triple therapy where they would give a proton pump inhibitor combined with a couple of antibiotics. And you can cure ulcers. This is common treatment. This is everyday, every general office all over the world. If you get an ulcer, what you're treated with is this triple therapy, a couple of antibiotics and a proton pump inhibitor, and it cures ulcers. Now, I don't think it cures indigestion, as my memory goes. You still have stomach upsets, but it cures ulcers, and there's also some talk about it preventing stomach cancers. I'm not so sure about that, but it does cure ulcers. But what happens when you stop taking your 2-week course of proton pump inhibitor antibiotics? What happens then? Well, H. pylori is every place. You kiss your spouse. She's got it. You catch it back. You put your finger on the table and put your finger in your mouth, and you get it back. So it's a temporary treatment at best. What you want to do to prevent ulcers, you want to put good food in the stomach. And of course, good food is starch with some vegetables and fruits. And I do want to take a little side trip here and remind you, if I haven't told you before, there are foods on the McDougall diet that cause indigestion, not ulcers, but painful stomach. And those foods are raw vegetables, even salads, but especially onions, green peppers, and radishes. Onions are terrible, and cucumbers too. They're notorious. But if you take and cook the onions or the other vegetables, then the irritating part, my guess is these irritating substances are there probably to fend off vermins that were going to eat the plants. They're produced by the plant to keep the insect from eating them. I'd have to research that, but that's just, and you can tell people I just made that up. But what happens when you cook onions is these are volatile substances, and they gas off, they boil off. And if you go to our program, any of our programs, particularly the 10-day or the weekend, we have a weekend coming up this May, I forget the date, 3-day weekend, May of 2017. You can look it up. Yeah, you should come because it's amazing. 3 days of all of our best talent. We'll serve burgers likely one day, and the onions will be thoroughly cooked, because if I ate the raw onions, the rest of my afternoon will be ruined. And the other thing that causes indigestion on our diet, we don't serve any fruit juices at the clinic except prune juice to get people's bowels moving. But we serve no juices because fruit juice causes terrible indigestion. And just think about grapefruit juice or orange juice. Just the thought of it, many of you will get a sour stomach. Now, you can eat the whole grapefruit or the whole orange and it doesn't bother you, just the juice. So when you're on our diet, be careful of raw vegetables, particularly onions, green peppers, cucumbers, and radishes. And be careful about drinking fruit juice. It's not, you don't make a fruit better by beating 1,000 times with a steel blade. So juices aren't healthier for you than the natural food. Okay, so that's the stomach bit. Now we're going to leave the stomach. So what do we got for the next slide? There we are. Now I got to get you oriented. Kind of look at Louise up there, and you see her liver, and out of her liver is kind of lying on, well, you can see the little green things, gallbladder, and I guess that doesn't orient you too much. Well, you see the small tube below the liver. That's that duodenal or duodenal area, that beginning of the small intestine that comes out of the stomach. So you see the liver kind of lies over that. Now look at the big picture. You see the liver, which is kind of the reddish organ there. And then you see this sac. Well, you're good. You can move that. That is sac. That's the gallbladder. And then you see the greenish colored organ off to the left. That's the pancreas. And you see there's a duct going from the pancreas into the small intestine. And then you look up there and you see, you follow the liver down and you see there's a duct. It's called the common bile duct that goes from the liver into that same part of the small intestine, the duodenum. Okay, that duct from the liver. We're not going to talk about the pancreas at all. That duct from the liver is called the common bile duct. And what that is, it's a common bile duct. All kinds of little ducts that are in the liver, they coalesce, like a tree. The branches coalesce into a trunk. And they coalesce into a common bile duct, which carries the bile into the intestine. Bile, its primary job is to digest fat. So the more fat you eat, the more bile you make to digest that fat. Now, at the end of those ducts, right at where the duodenum is, there's a little sphincter that opens and closes. That sphincter's name is Odie. That's his name, Odie. That's what we would call him in anatomy class. And between meals, Odie is closed because you don't want bile squirting into your intestine when you don't have any food in there. So Odie's closed, and when Odie's closed, the bile backs up into that green sac, which is called the gallbladder. And when you eat, what happens is the gallbladder contracts and Odie opens up, and you squirt the body, the bile is squirted into the intestine onto the food and mixed up with the food to digest the fat. Okay, that's what those ducts do, and that's what the function of the gallbladder is. It's a storage sac for bile between meals. And let's go on to the next slide if we can. All right, there's your gallbladder. You see what it's filled with? It's filled with stones. Those stones are made of cholesterol. The hallmark of gallstone formation is supersaturation of the bile with cholesterol. Now, how do you think you get the bile supersaturated with cholesterol? Well, cholesterol is only found in animal foods. And gallstones are characteristic of people who eat the Western diet. There's some other infection-related gallstone issues, but they're not common for Westerners. Almost all Westerners who get gallstones, their gallstones are made of cholesterol. And how often do people get gallstones? Well, statistics are about 30 to 40% of women in their 40s and 50s have gallstones. But they don't hurt. They're just sitting there. There's an acronym that medical students learn to help give you a guess whether somebody has gallstones. It's, I guess it would be called the 4 Fs. Female, fat, 40, fertile, and the 5th one they sometimes add is flatulent. Female, fat, 40, fertile, and flatulent. And you, in other words, they have bad GI distress. That's what flatulence refers to. So that's an acronym every medical school student knows. Now knew when I was a student, and probably knew 100 years before. Female, fat, 40, fertile, and flatulent. Okay, so you get supersaturation of the bile with cholesterol because it's supersaturated. It coalesces into stones, and now you have gallstones. And they just sit there, and they're no trouble at all. As I told you, maybe 40% of women in middle age have gallstones, and they don't even know about it. They're asymptomatic. And you might find it, say, with a chest x-ray, or they're looking around with a sonogram or something. They may find these gallstones that aren't bothering you. And there's a chance the doctor may say, we got to take those out. They could turn into cancer. You know, ladies and gentlemen, the chances of them turning into cancer is about 1 in 10 million. Is really unlikely. They'll also tell you, well, those gallstones, they could block up the cystic duct, which is the little duct before the common duct. It's the duct that goes between the gallbladder, that little tiny 1-inch duct there. That's called the cystic duct. That a gallstone could get trapped in there, and then you could have a gallbladder attack. And that is true. And that could be a problem. The gallstones, they sometimes will pass completely. Of course they do. They pass completely. But sometimes they get stuck, and then you're in horrible pain. You could become jaundiced. Yeah, you can die. I mean, you can get really sick. So the doctor will scare you into having your gallbladder out with that threat that you could get a gallbladder attack later to a lodged gallstone. But ladies and gentlemen, there have been probably a dozen studies done looking at what the chances are of you being helped versus harmed by taking those gallstones that don't hurt you They're asymptomatic gallstones out. So they set up studies where they take a group of people and they take their stones out immediately. They take the gallbladder out. You can't just take the stones out. You have to take the whole gallbladder. And so they take the gallbladder out and they compare them with a group that they left the stones, the gallbladder in. And they compare the chance of dying and being hurt over the next many years. Well, in each and every study, and this is a big argument, especially for those people whose business is to take out gallstones. There's been a big argument whether we should take out those gallstones that don't hurt. And the studies say, don't do that. That you're at greater risk of being harmed, like with the surgery, and people die from that surgery. They sometimes get their common bile duct cut, and boy, is that a disaster. You're more likely to be harmed by immediately having those stones that don't hurt taken out than leaving them alone until someday they might hurt. And that doesn't very often happen. Most of the time you die with your gallstones, and then if you donate your body to the medical school, the medical students, they have something to play with during their autopsy class, during their anatomy class. You know, oh, hello, look at my cadaver. Look at all these stones in the gallbladder. So leave for the students. Anyway, that's kind of the way it is. Now, I want to add one other thing here. Again, I've been around a half a century doing this. I'm not half a century old. I'm 70 years old, just about. But I've been in medicine for a half a century. And the way we used to take gallbladders out is we would take and make a big incision, a 9-inch incision right under the right rib cage. And that's a big deal, really hurt. I mean, really, people tell me that incision is the most painful incision of any place in the body. I've been told that. Well, that's how we did it. And then we got the development of these scopes, laparoscopes with instruments with little scissors on them and stuff. And we started removing these gallbladders through laparoscopic surgery, where we put a couple of holes, little 1-inch, half-inch holes in the abdomen, and you go in there with these scopes, where you look and you cut and so on, and you take the gallbladder out with this rather non-invasive procedure. You know, when that technology was introduced, the incidence of gallbladder surgery went up 400%. 4 times more gallbladder surgery occurred with the introduction of that instrumentation. Why? Because patients said, oh, it's no big deal. And doctors made a heck of a lot of money doing it. So that was kind of interesting as to the change in the incidence of gallbladder surgery after the introduction of the simple technique. Anyway, so leave your gallstones alone if they don't hurt. Now, if they do hurt, the time-honored treatment for gallstones is a low-fat diet, and then the pain goes away, and then you die with your gallstones. But if the pain doesn't go away, maybe the only thing you can do is have the gallbladder out. And now you don't got a gallbladder. So where does the bile get stored? It doesn't. It comes out of that common bile duct. It goes to OD. OD has to open up. And so that bile constantly drips into your small intestine, and there's no food in there to mix up with it. And so you get chronic irritation of your intestinal tract from this bile that should have been stored in the gallbladder, but can't be because the gallbladder is gone now. And now from that chronic irritation, you get diarrhea. You know, about half the people who have their gallbladders out, still have troubles. And a lot of them, the biggest trouble is chronic diarrhea, because the bile acid gets into the large intestine, irritates the intestine, and they're in the bathroom on the toilet 20 times a day with watery stools. Anyway, you can fix that. Because remember, I told you bile is made as a consequence of eating fat. So if you don't eat fat, the liver doesn't make much bile acid. And when you eat plant foods, it has a whole bunch of fibers and other plant parts that mix up and activate that bile. And I take care of people who have chronic diarrhea. I take care of people secondary to removal of gallbladder or other problems that they have in their intestine. I take care of people who literally live in the bathroom. They've got their computer terminal in there. They've got their telephones in there. They're having 20 watery stools or more a day. I have people that tell me they haven't been able to go to a business meeting in 2 years. They haven't basically been able to leave the house. They can't go on an airplane because of this chronic irritation of their large intestine from the bile. Now, what I tell them is I say, just change your diet, it'll be gone in 3 days. And they get mad at me. Why are you treating my serious problem so lightly? Because it will. It was shown by Andreessen in the journal Gut in the 1970s. He took people with ileopathies that had 20 watery stools a day, and he put them on a low fat. This is in the 1970s in the journal Gut. And every medical student should know this, and every doctor should know this, and they don't. And what he found is that within 2 or 3 days, they were having 1 or 2 formed stools a day. And just think of all the suffering patients out there that don't know this because you can't package it in a drug and sell it to somebody at CVS pharmacy. It's just simply changing the diet. So it's, I can't tell you how happy I've made many people who have this chronic diarrhea. And we have to go here quickly, don't we, Gustavo? Okay, so I'm going to add, because I know you have something to do right now, yes? Thank you.
Right.
All right, the one thing I'm going to add is that on occasion I add a bile acid sequestering agent called Questran or Cholestid, which sequesters the bile and stops this chronic diarrhea. And I'm sorry we have limitations today, but we have to go. We'll just continue this discussion next time. Will that be okay?
Yes, I apologize, everybody. I do have a meeting that I need to attend, and so we'll close today. But how about if we take the questions, Dr. McDougall, at the beginning of next webinar next week? Is that okay?
Well, and also I would probably like to go over this diarrhea gallbladder thing really quickly next time too. Yeah. And then we'll go on to our next section, and you're all going to go out and buy April's Martha Stewart Living Magazine, and you're going to look for the lady with endometriosis and the people, and I'll have a copy of the broad study that came out from Australia on our diet, the largest weight loss randomized control trial ever done. And who knows what's going to happen between now and next week, Gustavo? Hey, you have a good meeting. Huh? And folks, it was very nice talking to you. I should have talked faster.
I wanted to just remind people that in case anybody lives in Texas or near Texas, that next week you will be here in Texas for the health event in Marshall, Texas.
Say that again. Where will I be?
Yeah, where will you be? Well, you will be in Marshall, Texas next week.
Okay.
Because you are the keynote speaker at the Health Fest.
Mary and Craig, my son, the doctor, Mary, Craig, and I will be at this Health Fest. And I don't know whether it's sold out or not, but you can go on our website and under the discussion board, it has upcoming talks, or maybe someplace else there's upcoming talks. Do you know what the name is? It's called the Health Fest?
I think it's called the Health Fest, yeah.
I would just put a link in.
You'll put a link on, and you can. It's going to be a great weekend. There are lots of other good speakers there.
It is. And I will be there, and I will be doing the live webcast. So if anybody,
you're going to be there too?
Yeah. So
Gustavo, we can't get enough of each other. We're together all the time.
I know. Okay. Well,
so you know the name. You're going to be there.
Yeah, I will.
And remember our May Advanced intensive weekend that we're having too. Sign up for that.
Right. I would put a note for both of those events. Okay.
Thank you, Salvo. Thanks for listening, folks. We'll talk to you next week. Bye-bye.
Bye-bye.